There we go.
So welcome everybody to Northwestern Geriatrics Clinical Geriatrics Grand Rounds. It is my deepest pleasure to introduce Dr. Katie Drago from the Oregon Health Science University. And she is a phenomenal superstar when it comes to age-friendly health systems. She is assistant professor, soon to be associate professor out in Oregon. She also got her bachelor's or she did her fellowship in Oregon Health Science as well as her residency. And she's also received the AHA's Next Generation Leadership Fellow as an age-friendly scholar. So I am super, and she's also on the EPIC Advisory Board for Geriatrics. And she's also been on the Geriatric Commission among the Society of General Internal Medicine. So it is my honor and privilege to introduce Dr. Katie Drago, who is going to be talking about the age-friendly health system that she's built at OHSU. So thank you very much, Katie.
Oh, thanks, Lee. That is that introduction makes me sound so much more substantial than I actually feel. It is an absolute delight to be here with you all and to talk about sort of where we are at OHSU when it comes to age-friendly health systems and where we hope to go. There we go. So I have no relationships to industry, and my only financial support is through my OHSU salary. We don't have any grant funding or anything for our age-friendly work. And then all programs and tools that I'm going to mention today are open source. So you should just be able to Google and find everything that we mention. My hope is that at the end of this, what I'm hoping will be like 47 minutes, is that everyone will have a sort of much more crystallized understanding of what the IHI's Age-Friendly Health Systems Improvement Program really is, what it entails. And then I want to make this more of a sort of case study about where we started at OHSU, where we've gone, how we've addressed some of the hurdles that we've had to tackle, and then offer some tips and lessons learned that hopefully will be really relevant for you guys as you walk with us in our age-friendly journeys. So why age-friendly? None of this is new. None of this is new to you in the geriatrics division or those of you who care for older adults. The share of the population that is made up of older adults is steadily on the rise. Sometimes people talk about sort of the aging or the graying of society. I prefer not to think about it that way. I just prefer to think that there's going to be more older adults in 2050 than there are younger adults. And so we need to be ready for that. This is data coming from the US Census Bureau, looking at that share of the American population that is going to be 65 years and older. And again, steadily on the rise. What's most important here, I think, and certainly most relevant for us, is that older adults are hospitalized at double the rate of middle-aged and younger adults. Makes sense. This is my everyday, certainly. And then the vast majority of those folks that find themselves transitioning through post-acute rehab and then into long-term care are older and particularly frail adults. And they're aging with their chronic comorbidities. I argue that this is a success of modern medicine. This is the consequence of people surviving conditions, 40, 50 years ago that they may not have survived in the past. And that's a wonderful success for modern medicine. It means those of us that care for older adults are caring for a much higher burden of chronic condition and fragility. And here's where I really wanted to get to, this concept of homeostenosis, which I know is no stranger to any of you that work in the care of older adults. But what I see on our inpatient service, and I think all of us see now, is that more of our patients are living their regular life closer to what's called here the precipice. They're using more of their physiologic reserves just to get through the day, just to live with their chronic illness or chronic fragility. And so it doesn't take much to push that person from the precipice to over the edge. And here's what this has meant for us at OHSU. This is data through the end of 2021 that my data analyst is in the process of updating. But our hospital admissions for those age 70 over time has just gotten steadily upwards. The trend is a little funky, primarily because of COVID. And then, of course, our elective cases in 2020 and 2021 are down mostly because of capacity issues, not because of need. And then if we break down the share of those admissions that include diagnoses for particularly notable geriatric syndromes like dementia, hip fracture, delirium, falls, again, the trend is steadily upwards. So our hospital population is becoming more skewed towards older adults, and those older adults are bringing in particularly notable and fragile conditions that we need to be aware of, and we need to adapt our care in order to address their needs. This is really the underpinning of where the IHI started to develop the Age-Friendly Health System program. There is a huge body of evidence, evidence I bet a lot of you are really familiar with, for what the right things to do are. There's a huge body of evidence around falls and falls risk assessment and intervention, around depression screening, around delirium mitigation and treatment, around goal concordant care beyond just end-of-life care. So we know the right things to do. The barriers and the hurdles are that these programs and these approaches are rarely implemented and then even more rarely sustained. And so that last part, the implementation and the sustaining, is exactly what Age-Friendly Health Systems is trying to get at. And so hopefully this is not completely new to anyone who's listening. If it is, that's okay. Age-Friendly Health Systems is a reliable set of evidence-based best practices for the care of older adults. And this was developed with a sort of expert consensus group that went through painfully over many, many sessions to distill down the sort of best practices in geriatric medicine into just those top 4 things and areas that are the most critically important, that have the most wide-ranging impact and effect for our patients. And then to turn those into definitions that address the unique needs of older adults in the hospital and critical care, in the ambulatory setting, in skilled and long-term care, and then to come up, build this as a program to where the 4 M's are delivered as a set. So we don't just have health systems that are really good at mobility, but really bad at medication management and so on and so forth. You gotta practice all of them together in order to do right by your patients. So the 4 M's, as they're listed here on this graphic, are what matters, medication, mentation, and mobility. There are some health systems around the country that have added their own 5th M, and you may read about the geriatric 5 M's out there. It's basically the same. It comes from the same 4 M's framework. Some health systems have added M's like multimorbidity or malnutrition based on the needs of their patient population. The 4 M's exist, again, for across settings with slightly different definitions across settings. And I included hot links here on this slide for the implementation guides for hospital and ambulatory care, long-term care, and then the 4 M's kind of as a global approach to care. And so here's those definitions. So what matters is basically what matters to the patient, and it's beyond end-of-life care. So making sure that we are at very least aware of what's most important to the patient. What are their values? What do they really prioritize in their life? And then using that as our North Star when it comes to crafting the patient's care into the future for them. Using medications that are safe and effective for the patient's conditions, and that don't overstep what matters to that patient or negatively affect mentation and mobility. Mentation includes screening, risk reduction, diagnosis, and intervention for delirium, dementia, and depression. Delirium obviously more important in inpatient care, dementia and depression sort of more upfront in ambulatory and long-term care. And then mobility is the preservation of normal movement and function, and then being careful and thoughtful to avoid things that negatively affect mobility and negatively affect independence. Pretty basic stuff, right? Those of us that care for older adults every day, these are the issues that reliably come up for every single older patient. This is still a fairly new program from the IHI. It's only really been around for maybe 5 to 7 years. and certainly in wide use only in the last few years. And so there is a dearth of really high quality, like scientific peer-reviewed data on outcomes. Like, what does this mean to a health system? What does this mean to a clinic? In addition to what does this mean for patients? There are some early anecdotal reports of reductions in readmission, reductions in length of stay, and then pretty significant improvements in patient satisfaction. But this is really an active area of research, and there's definitely more to come here. I can tell you that at OHSU, we have looked, we have data on our own internal outcomes that I cannot share with you, and it pains me that I cannot share it with you, but I can tell you that it is overwhelmingly positive impact to our health system. So how to become age-friendly. And again, I want this to be more of a case study, and hopefully there will be some tips and pearls and tricks that you guys at Northwestern can take away and take back to your settings. Little bit about us. We are a level 1 trauma and academic medical center. We're also the safety net hospital. So we take unfunded, Medicaid funded, partially insured, catastrophe insured patients. We don't care who you are. We will take you and care for you. We have 2 affiliated community hospitals in the Portland metro area that are under the OHSU Health umbrella. We have 12 primary care clinics also across the Portland metro area, 2 affiliated post-acute and long-term care facilities that are under our umbrella. And then the whole place is crawling with medical residents, fellows, and other trainees, including learners of other disciplines. We've got nursing students, PA students, social work students, PT and rehab students, health administration students. They are literally coming out of the woodwork. So we're actually, based on what I know about Northwestern, pretty close. We're pretty close cousins, it feels, in terms of what our day-to-day really is like. This picture here is the picture of the tram, the aerial tram at OHSU Hospital, which is what, like, our claim to fame. We've done some demographic research looking at just the share of older adults that make up our patient population, and our patients really do reflect our community, kind of with one caveat. So Oregon in general, and particularly Portland, is overwhelmingly white. This comes from a pretty racist legacy that was left to us from the 1800s and early 1900s in Oregon. We actually had constitutional amendments that prohibited people of color from settling in Oregon. And it was really not a safe place to be if you were a person of color. And so that legacy persists in Oregon, and particularly in Portland. And so our inpatient community in particular, again, is overwhelmingly white, same with our ambulatory community. And we actually have a pretty sizable share of our population that has either left their racial and ethnic identity blank in their chart or hit decline to state. And the way I interpret this is that I wonder if a large share of this population are people of color who are afraid of being stigmatized by their healthcare system. And so even though our persons of color shares of the population that we know about look a little low, I wonder if that's artificially low. So here's where we started. My bosses and I read about age friendly. We knew it was coming down the pike, and we said, we got to do this. and that was a great feeling. And then the next question is, okay, where do we start? And the first thing we did is we got together in sort of our little core group, and we went exploring. So we went back to our respective settings of care, and we asked around what existed in the realm of the 4Ms, who owns some of the processes of care that already existed. Like, we already had a steady fall risk assessment protocol and screening protocol in our primary care clinic, one of the 12. And Elizabeth Ekstrom actually was the sort of driving force behind that, who's our chair of geriatrics. And so we already had a really good mobility screening process in the clinic. But what matters really was poor and really kind of individual, and it was the Wild West. And we didn't really realize that until we went around and started asking people questions. We also try really hard to incorporate some disenfranchised groups' perspectives. So even to put ourselves in their shoes, to ask, what about your LGBTQ patients? What about your persons of color? What's your feeling about the kind of care that they receive? Do they receive it at the same amounts? We made process maps, for what systems did exist. And then we went daydreaming and kind of thought, and we still do this, think about what do we want the health system to look like? What do we want people to walk away from us with and feeling about their care? I like this cartoon because this is really how it felt for us. And we started working top down, bottom up, and left right. We would talk to anybody about anything, any part of age friendly, any part of caring for older adults. Our goal at this stage was just to learn and to listen, look for those pain points that really were getting to people and really frustrating. Look for those workarounds that were really frustrating. And then we started to engage some and loop in some existing clinical champions in each setting, like Elizabeth, and then developed our age-friendly sort of core group into some setting-specific improvement teams. So I actually head up our inpatient age-friendly improvement effort. Emily Morgan, who's one of my colleagues, is head of our ambulatory effort, and Kate Edstrom, who's a nurse practitioner, heads up our long-term care effort. But this sort of developed over time as we went through the sort of learning and listening process, and then wanted to talk about how can we engage people to start working in these areas. And then our focus to this day has been to tie the 4Ms to every single level of team priorities. So when I hear about institutional efforts in mortality reduction, my answer to that, to anyone who will listen, is, have you heard about age-friendly health systems? When the Department of Medicine developed their quality improvement infrastructure, my first comment to the vice chair of quality and safety in our department was, have you heard about age-friendly health systems? Can I tell you about this? And really our approach was to be the solution. So whenever anyone had a problem, and it really did work out this way, that age-friendly health system had, at least a part or in whole, the solution to that problem for older adults. So here's our timeline. Here's our journey. I don't want to belabor this, but it's really been a long journey. We started this effort by becoming participants in June 2020. So we were working on our sort of learning and listening tour back in 2019. And then slowly but surely, we have certified the hospital. All internal medicine, or all primary care clinics, both family medicine and internal medicine, are now committed to care excellence, not just at OHSU, but at all of our affiliated hospitals as well. And then our first long-term care setting became a participant last year. They were also a part of the pilot to develop the long-term care 4Ms. So we, whenever IHI has called upon us to help out or give us our insight, we have never said no. And they've been really amenable and really open to hearing what we have to say and listening to kind of our pain points in order to grow the program. Data was a real focus for us early on. And so we wanted to, because it is really important. I know it sounds kind of esoteric, but it is really important to have meaningful metrics and reliable data sources in order to know kind of how you're doing. And where the problems are, and then how what you're doing might be making a difference or not making a difference. So we wanted to have this up and running early on. We really struggled. Sometimes the systems of care for each M really were not perfect and really needed to be overhauled. There's still a lot of work that we have to do in some of our 4Ms. And so even though our ideal metrics may not have been feasible based on how the system was working, we had to go with what was available. And so this is really speaking to not letting the perfect be the enemy of the good. And then fully acknowledging that our metrics are going to change as our systems evolve, as our processes change. We really do want to match up the metrics to the system. We've been looking not just in provider level data, but in nursing level data, in rehab level data, in hospitalization, admission level data. And we have a data analyst who's a master's in public health, not a PhD, not a health system economist. She has been amazing at gaining access to these different repositories, at investigating, what are the metrics that are available, what makes sense. And then using creative thinking. So for medications, the IHI talks about 7 classes of medications that are ideally to be avoided. And that's one of the metrics that they recommend tracking. We thought for a hot minute, we do not want to run reports for all 7 medication classes. That's just a lot of data and a lot of charts to keep track of over time. So instead, we run one single report looking for patients that had none of those 7 classes of medications ordered. And so we sort of clump them all together as one just sort of high risk medications. And we're looking for the inverse, the patients that were free from those medications. And that, even though it's a little backwards, that actually has streamlined our ability to look at the data. We started with Excel spreadsheets. Bree, our data analyst, was pulling reports from our Epic, backdoor databases and dumping everything into Excel. She's become an Excel master. I don't even understand the depth of what she can do with Excel. And she was the one that actually found that OHSU has a system, has a software for developing and maintaining control charts over time. So she actually has stood up our Statit monthly performance data for inpatient and is working on it for ambulatory. And so you can see here on the right-hand side is our overall 4Ms performance, and it's not perfect. We've actually got quite a lot of work to do. We've had some blips, some good, really excessively good months, and then we've had some really, really poor months during our Delta and Omicron surge of COVID. That's the sort of 2021 red spot there. That rebounded, and now we're sort of steady between 40 and 45% of all of our inpatients receiving 4Ms care. When we look at just mentation, we're a little bit better. We're at about 70%. And this is I get 4Ms data, and then I get data for each of the Ms over time. So we're going to dive in and talk about age-friendly health system in the clinic. And I'm going to go a little quickly because I'm running a little low on time. For us to build and build up to age-friendly certification for all 12 primary care clinics, this was a case of opportune timing. So when we were starting, really starting this process, there was institutional consolidation of our internal medicine and family medicine primary care, which previously had been 2 completely different worlds. They had different processes for things like depression screening, different processes for fall risk assessment. It was just the Wild West. Part of this consolidation of primary care and the development of our population health program was everything you see listed there: standardization, which was a magic word, for us. And so we were able to get in on the ground floor and say, while we are overhauling every clinic's standard processes, we want to embed the 4Ms into that process. And our Office of Population Health was actually really jazzed about this idea. And was able to help sort of be our executive sponsor to like expanding our steady screening to all 12 clinics, to adopting better depression screenings from family medicine, which actually did this really well, into internal medicine. And that's been really a godsend for us. Here are our ambulatory 4Ms metrics. I'm not going to go over each and every one of these. You may notice that some of these are less than perfect, like the surrogate decision maker in our ACP navigator. That really doesn't speak to the entire breadth and depth of like goal concordant care. The problem, and it persists to this day, is that our systems, our processes for goal concordant care really are highly provider independent. Just again, sort of the Wild West. And so there is a group right now, a cross-setting group that is looking to standardize those processes in ambulatory care and then in acute care. And so as those processes really come into form, these metrics are going to change to reflect the sort of new changes and adoption in our systems. You also may be thinking to yourself, some of those 4Ms quality metrics actually sound very familiar to me. And it's probably because of this, because these actually are very, very similar, if not outright the same as the CMS quality improvement measures and quality assurance measures. And so this actually was incredibly helpful for us to go back to our population health management group and say, we get penalized. There's the risk for financial penalty if we don't meet some of these CMS quality metrics. Age-friendly health system can actually directly help with that. There were systems, policies, and procedures already in place, but again, each primary care clinic had different systems of care for each M. It was the Wild West. So I'm not going to dive too sort of deeply into this, but for what matters, what we're really focusing on and what our institutional improvement group is really focusing on is annual serious illness planning documentation. So again, not just end of life, not just advanced disease, but those with any sort of significant diagnosis, talking about what matters. What's most important? What are your priorities? What are the sort of those non-negotiables in your life? What are your goals? How should we handle things when your health worsens? And then documenting these in a place where everyone across the spectrum of care can have access to it. This is our advanced care planning navigator in Epic. Every institution has something a little similar to this. It just may be called something different. This is our one-stop shop for all things sort of goals and decision-making and priorities. There's a whole section there titled ACP Notes. And what we've learned, fortunately, is that whenever anyone, either in the hospital, long-term care, or ambulatory care, puts in a note where the note type is ACP Note, it automatically files into this navigator and it stays there as the patient moves across settings. We did not know this existed for a long time, like an embarrassingly long time, and have come to realize like this could be a really, really powerful tool for people like me in acute care to be able to go back with one click and see patients of Elizabeth Ekstrom's and Emily Morgan's in the clinic where they've already had these conversations about where the limits should be in their care. So this is turning out to be a main focus of our institutional improvement group. Mentation in the ambulatory setting, there's two foci. One is depression, one is dementia. You can see here we screen with either the PHQ-2, PHQ-9, or GDS, and that's really provider independent. We track all three in terms of our metric. And then screening for dementia, the USPSTF has recommended against routine screening. And so what we do is we do sort of a general cognitive screening. We ask people, do you have any problems that you've noticed with your memory? Are any of your daily tasks, the basic stuff, becoming more difficult? And we ask those of family as well. Then if people say yes, to one of those questions, we go in and we do a deeper assessment and follow up. We've had a dementia smart set that includes orders, for the dementia workup, imaging orders, so resources that can be printed off from the smart set for families, billing codes. It's really one-stop shopping for cognitive assessment. And so we've built on that and made that available to all 12 primary care clinics. There's local resources for things like counseling at the Alzheimer's Association of Oregon, so on and so forth. And then this automatically puts a health maintenance modifier in the health maintenance tab to repeat cognitive testing annually for these patients. So this is not so much screening, it's tracking progression of illness. Medications, again, it's those seven medication classes. I think there's actually 8 here that we track. But again, we look for the opposite. We look for the share of patients that don't have any of these 7 medications on their active medication list. And then we put all 4 of these M's into practice. So mobility is our steady falls assessment and intervention. Depression with appropriate follow-up, cognition, as we talked about, our annual serious illness documentation, and then medications. Putting it into practice was, once we sort of clarified all this, became even more clear that this is all standard fare for a Medicare annual wellness visit. And so we were actually able to enhance our existing Medicare annual wellness template with some of these tweaks to make it readily easy for the providers to be assessing all 4 M's and sort of doing right by their patient. We made it easier to do the right things. And so what they noticed in the inpatient setting is that medications was a real opportunity for us to improve care for our patients. So we've done sort of one big PDSA cycle so far of a provider-led approach to deprescribing. There was one like whole clinic provider education section, pretty easy, pretty straightforward training session. And then as part of everybody's panel review that they do periodically, they got lists of patients on one of those 8 classes of medications. And then were asked in the Excel spreadsheet to choose an intervention, what they were going to do about that, either stopping the medication now, maybe it was something they weren't even taking. Mark is currently tapering. We're going to talk about this as a visit, or no action. They were also given a toolkit that included the Beers criteria, MedStopper for taper advice, and an anticholinergic burden calculator, along with the Canadian Deprescribing Network guidelines, videos, patient education. And then they were given a sort of do this, not that tip sheet that was put up in each clinic room at each workstation. And here's really what this looks like. So for each of these medication classes, why this is risky, here's the list of what you can do instead. I know this looks like a lot of text, but this again is like up behind the computer, so you can find it really easily, track across from the medication you want to address, and then be right there. We actually included estrogen, HRT in this because we do have a fair amount of patients that are still inappropriately on HRT in our clinic. And it's a question that our outpatient geriatricians get asked a lot. And here's what they found. So 10% of patients actually had an inappropriate medication on their list, and the majority of these were female patients, which we also found in a separate equity review that's at the end of these slides. Almost the entirety of the providers completed their panel review. This is just a standard part of practice for our providers, so pretty good adherence. They felt about half of the patients that were on an inappropriate medication felt to be exempt from review. So these were patients for whom maybe they had tried another therapy, didn't work, they kind of earned the high-risk medication, and it was okay for them. So those patients were exempted from further action. And then at 6 months, for the other half of those patients that were felt to be candidates for deprescribing, about half of their medications were either tapered or stopped. And what this meant is totally clinic-wide, this was a 2% decrease from 10% to 8% of the total population of patients with an inappropriate medication on their list. This intervention actually just got published like a month ago in Gerontology and Geriatric Medicine. And so we're very, very proud that we now get to share this data with the outside world. We're going to shift gears and talk about age-friendly in the hospital. We actually were really lucky. We had a lot of systems, policies, and procedures that were already in place. So CAM or CAM ICU screening for every patient, every shift was actually a policy, nursing level policy and requirement of every nurse in the hospital for every patient. We had a geriatric prescribing context, which my team helped develop, which was age-appropriate defaults, dose defaults for 51 medications where dose actually really is important. Think about things like antipsychotics and opioids, where we start low and was very different from actually the previous defaults that we had set in place. MOVE assessment, which is basically a hospital adapted get up and go. We had a real institutional focus on documenting surrogate decision maker, and then every trauma patient actually had a sort of goals of care, serious illness or serious injury family meeting between the providers and the patients at 72 hours after their admission, if they were still in-house. And so we had pieces already existed, but they were kind of housed in different places. It was all just very piecemeal. So here's our inpatient 4Ms metrics. Our What Matters metrics here also could use an overhaul, but again, our systems are actively changing because of the institutional sort of multidisciplinary group that's working on this. The rest are fairly standard. We're looking basically at ensuring patients are getting a CAM every shift. We're looking at patients without any of those main 7 medication classes on their list. And this includes new starts in the hospital and chronic medications that get translated into the hospital. And then our get up and go, or our move assessment, completion every shift. Here were our tier 1 quality and safety priorities when we started down this road in 2019, 2020. Pretty standard fare, right? Everybody wants improvement in these areas. But we were over the moon when we saw this list, because 4 of these tracked directly to 4M's priorities and age-friendly health systems. So for months, our team, our inpatient team, was talking to everyone saying, these are your tier 1 priorities. We are the solution for this. You want to address cognitive and behavioral care, falls, medication reconciliation, mortality. We can do this for you with support for age-friendly health systems. And so we went on a roadshow starting in December of 2019. We talked with hospital leadership, nursing leadership and managers, staff educators, and talked about exactly this, how the 4Ms, what the 4Ms could do for them, for quality metrics on each of their units, for the tier 1 quality and safety priorities. And we got a lot of real interest. We were all set to disseminate unit-based control charts for each of our 4Ms metrics to nursing leaders on each of these units, and start really supporting local champions to address each of these 4Ms. And then COVID happened and everything was shelved. We had resources completely redeployed. All non-essential work was put on hold. Our hospital CEO said on the record, pause all non-essential work that you're doing. Our institutional priorities completely changed, and our age-friendly team was left kind of pulling out our hair saying, age-friendly could actually help more older adults get through this, right? Especially with delirium being such a big part of COVID infection. We can help with this, but everything got derailed, everything. And so where we focused was we shifted our focus to areas of the hospital that maybe were less affected. And so what we did is we worked with our GE, we have GE Healthcare as consultants for, processing and efficiency, patient transit through the hospital. And they actually stood up a real-time data infrastructure that we call Mission Control. Sounds very space agey, and it really is very space agey. And they wanted to build with us a tile, a sort of real-time tracking data tile, looking at the intersection between medication, high-risk medication, and delirium, because it was a major driver of prolonged length of stay for our patients, still is. And so we developed this high-risk medications in delirium alert tile. And this is a real-time alert that would fire. So patients would show up in real time on the tile when they were CAM positive for 2 consecutive shifts and had an active medication order for one of 14 high-risk medications. And this includes things like low-hanging fruit, scopolamine, an H2 receptor blocker, Benadryl, benzodiazepines. I mean, the real low-hanging fruit stuff. And so we did, once this tile was built, our neurology colleagues, neurology and neurosurgery, who were relatively spared from the impacts of COVID, said, you know what, we're seeing a ton of delirious patients. We really want to work on this. It's dragging down our length of stay. You've got this tile. We want to pilot it for you. Great. So we did a 6-week implementation cycle where we embedded use of the tile into daily interprofessional rounds that they already had on our neurology and neurosurgery unit. The nurse leadership on those units did a sort of recertification, recommitment to CAM. And so actually went around and sort of recertified all day shift and night shift nurses on their CAM assessment competency. And we looked at some health system level outcomes and then patient level outcomes, and then broke down the outcome measures by sex and by racial and ethnic identity to make sure that we weren't missing anybody. So here's our control charts from that time. The pilot was in sort of March, April of 2021. I know it's a little old now. You can see there our medication use based on our 7 medication classes was about 70% were free of any high-risk medication. But again, there's not perfect overlap. Our medication lists were a little different. And then mentation, because of the CAM sort of recertification, the CAM competency research, we saw a dramatic increase in CAM completion all the way up to 87%. And here's our outcomes. So I know this chart, Excel snapshot is a little tough to read, but I pulled out some of the highlights. We saw major changes. There was nothing else happening on the unit at this time. There were no other interventions or things being piloted. The nursing staff was actually fairly stagnant. This was before a lot of staff turnover. And what we saw was a dramatic reduction in both ICU and overall hospital length of stay, significant reductions in hospital cost, a dramatic increase in patients discharged directly home. Some of this may have been driven by COVID and patients wanting to go home. So there is a little bit of a caveat there. About 30% fewer patients diagnosed with delirium, about just under 30% fewer patients receiving antipsychotics, and then 12% fewer days where restraints were ordered. So across the board, health system and patient level outcomes, we saw dramatic improvements. When we broke things down by sex and by racial and ethnic identity, we noticed that in some areas, the benefits were not always shared. So I want to point your attention down to race and ethnicity. The blue is sort of pre-pilot, and then the orange is during the pilot phase. That length of stay actually went up pretty significantly for our patients that identified as Black, and same for patients who identified as Hispanic. I do want to call out again that our population in Oregon is overwhelmingly white. So it is quite possible that these dramatic increases in length of stay were driven by only 1 or maybe 2 patients for whom the longer length of stay was actually necessary. So again, our N here is not huge. So we're not able to draw any huge conclusions here. And when we looked at restraint use by sex and by ethnic identity, we saw the same, particularly in sex, that we actually had more restrained patients that identified as female during the pilot phase than we did male. And even in our overall numbers, that disparity is actually hidden because of the dramatic reduction in males that were restrained. So we knew we had some opportunity here. There is some bias inherent in the system that we were never really able to pinpoint very well, but we could see it at least. And so what we tried to do as COVID loosened the reins and more people had more brain space to sort of focus on the future is we've really worked hard to empower and bring local champions into the fold. So we had a pharmacist on the neurology unit actually become a CGP. He's our first and only CGP in the OHSU Health Network. There was a physical therapist, veteran physical therapist, who actually went and got certification in neurologic and cognitive disorders in acute care. And so we brought them both into the fold. They are champions for medications and mobility in our age-friendly team. We have nurse leadership mobility champions that are also sort of associated with our age-friendly effort. And then this interprofessional group overhauling Gold Concordant Care is well aware and sort of partnered with us in age-friendly to work on what matters. I think I've got enough time to at least look at our equity work. So there's a new requirement to become age-friendly certified, even to become a participant. You have to document how equity will be measured and tracked. We were a part of the Age-Friendly Health Systems Equity Task Force when they were considering making some changes to the program around equity and equitable care. And so we were part of the group that actually talked about how feasible is this, how hard is this, how do we raise the bar so that we're addressing this issue without making it so onerous that health systems cannot become age-friendly. And here's what we did. So we had all this data, right? Our focus on data from the beginning actually meant that we had access to patient level demographic data, including sex, race, ethnicity, language is a really important one for us. Our sexual orientation and gender identity data is really like garbage in, garbage out. There's just not enough there for us to make heads or tails of. And so this was our first foray. This is Internal Medicine Clinic. So one of our 12 primary care clinics on the Hill. And we looked at, again, our overall 4 M's are up here in the blue bars in the corner. Not perfect, you'll notice. And then we looked by each of the 4 M's, broke them down by ethnicity, by sex, by race, by MyChart activation status, which it turns out is one of the more potent kind of diversity metrics that we could find, and then by language. And once we did this, it was actually fairly easy to see that the benefits are not shared equally across groups. And so one of my colleagues, Emily Morgan, was actually able to publish this data in the Journals of Gerontology Series A. This was back last year. And here's what they found. Here are the results from the logistic regression analysis, that females and English speakers were far more likely, statistically more likely, to receive appropriate What Matters care, so more appropriate serious illness care, than males and then non-English speakers. Females and those with good MyChart use or MyChart access were more likely to be on a potentially inappropriate medication. And the way Emily sort of put this into context is that thinking those patients that had more MyChart access maybe had more sort of a lower bar, easier ability to contact their PCPs or covering providers when they had any sort of new symptoms or any sort of changes, and easier access for providers to prescribe one of those higher risk medications. And then under mentation, under the cognitive screening, they found that people that had MyChart activation actually received their cognitive screening more often than patients with no MyChart. And what they thought about this was actually about the proxy utilization for these patients, that it's pretty common for people with some cognitive impairment to actually have a spouse or an adult child or a close friend, someone actually have proxy access to their MyChart, and wondering if that was sort of a driver for more appropriate cognitive screening. We did a similar analysis in acute care, although it was not published. And we found that these disparities, particularly What Matters and medications, actually followed patients into acute care. We saw very similar statistically significant disparities in those exact same domains, English speakers and females, in acute care when it came to What Matters and medications. We track the 4 M's and each individual M broken down by race, ethnicity, and language. We just do it every quarter instead of every month because our charts got to be far too noisy. And so you can see here on the left, this is our overall 4 M's performance. And then in the middle is broken down by race. And then on the right-hand side is broken down by ethnicity. And roughly, the overall trend here does seem to fit. There are some quarters where we do much better in one group and much worse in another, but everything does seem to have enough noise that the average really does sort of fit the overall trend. There are some limitations here in our equity world. Again, Oregon is an overwhelmingly white state. We have a real legacy of racism, redlining, state-based redlining that persists to this day, that we are one of the least diverse states in the country. That is changing to some degree, but it is still quite prominent. And it does limit some of the conclusions that we're able to draw from our research. There's a sizable minority, like we mentioned before, that decline to offer racial and ethnic identifiers. So it is kind of a black box, no pun intended, into being able to do this kind of work. And then even less available sexual orientation and gender identity identifiers. Our health system actually has made this a priority within the last year or so, because there are lots of groups trying to put an equity lens on their research, and this is a barrier to more than just us. Our journey is just beginning. We are ongoing. Things are happening all the time. I actually couldn't put in everything that we do and want to do at OHSU. It was a real tough decision. But our journey is still ongoing. We're going to make changes. Things are going to change all the time. And that's part of the fun, I think, of Age Friendly, is that there's real, 2 or 3 steps forward. There's maybe 1 step back at times, maybe 4 steps back in terms of COVID. But we're still committed to being age friendly. There's still champions, hiding all around the hospital that are really engaged and invested in this work. And so we're still rooting out people that are really local champions. And that's what we want. We want to build things up locally and not so much from the top down. That was derailed by COVID, but we're getting back on the tracks. So here's sort of a final tip slide. We talked about these things already, but I do want to highlight the last one, and that's be the solution. Older adults are driving hospital care. They are the ones that are generating more of the demand for hospital and for even ambulatory and serious illness care. And so providing high quality, evidence-based geriatric care actually can address almost all quality priorities, safety priorities. And so there's real opportunity here for us to walk around and say, I've got the solution to your problems. And that will get people's attention. My group is working to put some research out there, so to arm other institutions with data that they can actually bring to their managers and say, look what they did at OHSU, we can do this too. Because we want to, we really feel strongly that we can be the solution, and we want to arm everyone to make that argument too. That is all I had. I know we started a smidge late, so I'm not sure if people are okay to ask questions a little bit later. Is that okay?
Yeah, totally. I love what you've been doing. I got to tell you, and I love the statement, be the solution, because there's so many things that geriatricians know, and we just look at the thing and you're like, oh. So how is it that you're able to identify champions who are not geriatricians? That's the toughest part that I'm seeing, because there's people that have high confidence but low knowledge in geriatrics who want to be the champion. You're like, that's not accurate what you want to do. So how do you handle those individuals, or how do you identify the right person?
Yeah, so we have those too. And we've definitely had to sort of be a bit choosy about our champions. I work inpatient. There's a whole team of us that work inpatient, and there's a whole team of us that work outpatient too. When you work in this setting, when you're actually doing clinical work, you know who the people are that you can trust. And so I know, and my partners know, when we see particular nurses' names in charts, we kind of have that like, oh, phew, thank God, kind of feeling. And we know just from the care, our clinical care of patients, I know which pharmacists I can go to with questions that may be out of their immediate expertise. Our CGP is actually a neurology pharmacist. And I go to him with questions about anticoagulation, about antihypertensives, about all sorts of things, because he actually went and he got his CGP certification. So even though he's primarily the neuropharmacist, we knew that Robert was like our go-to guy even before he became a CGP. Same with Jackie Lombard, who's our certified PT. She, we shared enough patients with her over the years that we were like, yep, I wish Jackie had this patient. Every time we say to ourselves, I wish so-and-so had my patient today, that's a person that we keep in the back of our brain that like, hey, they may actually be a really well-suited person to be part of our age-friendly effort.
Oh my God, that's fantastic.
Yeah, it's not this call for champions. It's this like internal screening process.
That is so awesome. So I want to thank you so much for an awesome presentation. And I feel like there's so much I can still learn from you as we're kind of trying to make our inpatient side more age friendly. So we'll definitely be talking. Our teams, they have so much to learn from you. So thank you so much for presenting. Thank you, Dr. Drago. Yay. And keep up the fantastic work. You're such an inspiration for what you're doing. So,
thank you guys so much for having me. Lee has my email if anyone wants to send questions, or ask me questions about the slides. It's just Drago, my last name, at ohsu.edu, but Lee's got it. So please be in touch. I'm happy to be a resource to you on your age-friendly journey.
Oh my God, thank you so much.
Thanks all.